Anyway, I'd like very much to welcome Elizabeth Roberts-Pedersen, who many, many years ago actually did attend this university as an undergraduate in the deep past. So it's lovely to have her back, and she's very impressed by the capital improvements on campus since then. So Elizabeth is a research lecturer at the University of Western Sydney and in history and political thought. And she's doing some very interesting work on psychiatry in World War II. This is a project on psychiatry in World War II in Britain, America and Australia. So we've actually just had a great little chat down in the coffee shop about psychiatry. And so yeah, I'm very pleased to welcome Elizabeth, and I'll let you kick off.
Oh, thanks very much, Lisa. And thanks for inviting me. Thanks for turning out at the end of semester. All right, so I'm going to talk to you today about my research into psychiatry during World War II. And what I want to do is outline some thoughts on one aspect of that research, which is the treatment regimes for British service personnel who were diagnosed with patterns of symptoms that were collectively known as war neurosis during the Second World War. I'm going to concentrate on what was described in professional literature as physical treatments for these neurotic disorders. So as the name implies, physical treatments were measures concentrated on the body, sedating it for short or long periods, convulsing it by chemical means or with electricity, and even cutting it in the case of prefrontal leucotomy or lobotomies, as they're commonly known, as a means for calming and quieting the mind. Now, various combinations of these physical interventions were in widespread use in forward psychiatric units, where service personnel were treated close to the front line, as well as in hospitals back in Britain. My argument is that the prevalence of these treatments for neurotic rather than psychotic conditions is extremely significant for our understanding of wartime psychiatry in Britain, and more broadly the development of post-war psychiatry in the Anglophone world. And this is despite the neglect of these kind of treatments in the scholarly literature. Historians of psychiatry have tended to emphasise the advent of group therapy as a means of constructing so-called therapeutic communities amongst psychiatric casualties as the most significant treatment method arising from the Second World War, as well as evidence of the quasi-Freudian inflection of post-war psychiatry in Britain and the United States. As iterations of psychoanalytically inflected talking cures, which expanded the therapeutic encounter between the therapist-patient dyad into group settings that replicated the social milieu in which the neurotic patient would eventually need to function, these famous experiments in group therapy and therapeutic communities at the Northfield Hospital are regarded as the key innovations in treatment regimes during the Second World War. Yet these were experiments, I guess, that were confined by time and place, and I think it's important not to magnify their importance if we want to map wartime psychiatry practices as a whole. Evidence from the medical press suggests that it was physical methods of treatment that were the most widespread means of combating the problem of neurotic servicemen who were thought to be undermining the efficient functioning of the British Armed Forces and flooding military hospitals. And in this sense, physical interventions were a pragmatic response to the strictures of wartime. As their leading proponent, William Sargant, this is a bit unfair. I don't think we should judge people on their passport photos if we do that all the time. But he's not sort of putting the best face forward there. This is the psychiatrist William Sargant. He later wrote that these physical treatments constituted some measure of revolution in the treatment of intractable neurotic symptoms, not only because they were the most efficient means of ameliorating neurotic distress. His idea was why engage in hours of what he described as useless talk when an injection would do the same therapeutic work in a few hours. But because these physical measures could be administered by service medical officers, so the MOs in forward units, as well as village physicians when soldiers returned home, so they didn't need a psychiatric specialist to administer these kind of treatments. In this sense, these physical interventions aimed at the treatment of neurosis, I think prefigured in many ways what historians and psychiatric practitioners have dubbed the biological turn in psychiatry in the latter decades of the 20th century, insofar as today the reigning paradigm or treatment paradigm for anxiety, depression, neurotic conditions is a pill prescribed by a general practitioner. And I'll return to this point at the end of the paper. All right, what did medical practitioners mean by war neurosis in the Second World War? Apart from a few unreconstructed neurologists who held to 19th century conceptions of mental disorder and assumed that physical lesions, some kind of physical lesion on the brain and the spine, were the root of psychiatric disorder, and that there was no real difference between the brain and the mind. By 1939, the majority of psychiatrists accepted the psychogenic origin of neurosis and understood their patients' symptoms as representative of unconscious and unresolved conflicts. Even William Sargant, whose later career, his post-war career, was marked by its vehement anti-Freudianism, excuse me, stumbling over Freud's name, it's always that's the ultimate Freudian slip, isn't it? Even though he was a vehement anti-Freudian in the post-war world, during the war he deployed psychoanalytically inspired language to understand the suffering of his patients, many of whom had survived the retreat to Dunkirk, and who now arrived in the Belmont Hospital in Sutton, where he worked for much of the war, in what he described as a pitiful state, with thin, pallid faces and an array of neurotic symptoms. Now, for Sargant, as for the majority of his peers, these were not men that were brought undone by a lack of courage, as may have been the assumption in World War I, or by the concussive force of enemy weapons, as was another explanation in World War I, but by the inability of their conscious mind to assimilate the full horror of their experiences. And a lot of the medical literature acknowledges this, and which I think is very interesting, that the retreat to Dunkirk, the subsequent evacuation, had been uniquely distressing for some men. This, by the way, from the Imperial War Museum, there's a collection of German photographs, German colour photography that was captured at the end of the war. And you can see this is the body of a British serviceman that's been washed up at low tide a few hours after the evacuation was completed. And this is from a German collection of photographs. But this evacuation meant men swimming out to ships, people drowning. It was uniquely distressing for a lot of these men that turned up in this hospital that Sargant was working at. And whilst the psychiatrists speculated that this inability to assimilate these horrific experiences were in part the result of what they called a constitutional instability or an emotionally dysfunctional childhood, the various symptoms collected under the rubric of war neurosis were first and foremost understood as a product of the unconscious mind. Now, psychiatrists tended to divide war neurosis in World War II into two broad types. First, they said that there was a war neurosis that was a condition of chronic anxiety, in which the sufferer experienced not only anxious and therefore often depressed mood, but an array of physical symptoms. So there could be respiratory or cardiovascular in presentation, so palpitations, chest pains, breathlessness. They could be mild in the digestive system, so persistent nausea and vomiting, or they could appear as neurological in origin, such as dizziness and headaches. In addition to this, a clinically very apparent presentation of anxiety, and still under the umbrella of war neurosis, were what was known as the hysterical conversion disorders, and they're significant for these physical treatments. Now, these were a clinically far more spectacular species of neurotic debility and far more reminiscent of the most emblematic cases of what was known as shell shock during the First World War. These were thought to occur most often amongst combat troops, such as the soldiers and the sailors treated by Sargant after Dunkirk. Now, the thinking here in these conversion disorders was that the unconscious mind literally converted the fear, rage, sorrow or guilt of afflicted servicemen, any strong emotion that could not easily be absorbed or reconciled by the conscious mind, into a manifestly debilitating physical symptom. This affliction would then render the serviceman unfit for future service and thereby protect him from further harm. These symptoms were described as functional to distinguish them from symptoms with an organic basis. An example of a conversion disorder would be functional paralysis of one or both limbs. Now, I was going to show you, because I get the internet working, famous footage this is from World War I. I haven't been able to find any footage from World War II, but from the Netley Hospital in Southampton, the Sealhaven Hospital, I think in Devon, which shows some very extreme versions of conversion disorder. You may have seen them on the internet. You can get them through YouTube or through the Wellcome Library website. And there's a lot of men. You can see here a man with apparently no organic basis for this, but very bad, I guess, problems with his spine, problems walking. There's a whole series of footage of men unable to walk, men shaking when they walk, seemingly unable to use their limbs properly. These are understood as hysterical symptoms, as conversion symptoms, and there's various forms of treatment that you can see on the tape, the footage there. These were other rankers, also, so they were not men from the officer class, which was probably why they felt they could film them. They were far more likely to have worn the pejorative label of hysteric rather than an officer who would have developed similar conversion symptoms. Such an officer would be described as neurasthenic. It's less pejorative. Now, in the Second World War, British service personnel were far more likely to be diagnosed as anxious or described as anxious rather than hysterical. And this is in part reflects shifting cultural interpretations of neurotic symptoms. changes in diagnostic practices, and in part the fact that many Britain's psychiatric casualties were occasionally far from the field of battle. Service personnel who developed psychiatric disorders behind the lines tended to be diagnosed as congenital and chronically anxious neurotics. But there were small and significant groups of service personnel, often former combatants, who did present with these extreme functional somatic symptoms that are depicted in these films from World War I. And it was these patterns of symptoms, paralysed limbs, tics, tremors, that presented in the survivors of the Dunkirk retreat who came into Sargant's hospital that first prompted him to begin experimenting with drug treatments. And this began when these drug treatments were successful. This begins his evangelising belief in physical treatments as the best treatment for neurotic servicemen, as against so much useless talk. Now, what form do these physical treatments take? I'm going to begin with these drug therapies, which was Sargant's first recourse when dealing with men with extreme somatic symptoms. Now, first and least controversially was sedation in its most benign and orthodox form, a small dose of sedatives to induce a full night's rest. And this was a simple transposition of a common peacetime method for calming agitated patients and approved of by the medical establishment for soldier and civilian alike. At the beginning of the war, the leading British medical journal, The Lancet, had urged the use of a dose of bromide, morphine injections, or the administering of barbiturates to assist in the treatment of confusion, excitement, loss of memory, or disorientation, and to forestall chronicity in victims of air raids. More extreme uses of sedation, though, were measures that amounted to what is described in the medical literature as continuous sleep therapy. For William Sargant and his colleagues at the Belmont, one of his colleagues at the Belmont Hospital, Elliot Slater, they later co-authored a best-selling textbook on these physical methods of treatment. Longer periods of sedation were crucial for treating service patients that had been through particularly harrowing experiences or presented with extreme or distressing symptoms. For these patients, they recommended what they described as continuous narcosis, on the basis that, quote, the longer the symptoms are allowed to last with the knowledge of the patient, the more deeply they will be ingrained and the more likely they will be to recur as future behaviour patterns. Continuous sleep could be achieved with a variety of drugs administered by the mouth or with an injection, but practitioners did need to be mindful of the importance of assuring quality of sleep, so sleep without delirium, hallucinations or other kinds of disturbances. Under this continuous narcosis, a patient might be made to sleep for 20 hours a day for up to 10 days. A similar rationale governed the use of insulin comas, or modified insulin comas, as they were sometimes described. There's a depiction here. This practice drew on a well-established asylum method of rendering schizophrenic patients comatose with constant but controlled doses of insulin for long enough for their symptoms to abate. During the Second World War, a modified version of these insulin comas, was applied to intractable neurotic patients to arrest what was described as the vicious cycle of anxiety and loss of weight. Patients were kept in a twilight state between waking and sleeping by balancing insulin injections with doses of sugared tea administered via a nasal tube. When sugar became scarce, small doses of insulin were alternated with large servings of potatoes to try and keep people in this twilight zone. Now, an older notion of feeding patients back to health was implicit in this method. Sargant was particularly enthusiastic on this point, writing that it is open to doubt whether a stable psychological recovery can be obtained without restoration of normal physique. But there are other benefits to this modified form of treatment. Patients never actually lapsed into a coma. So this is the modified insulin coma. Because patients were kept in a twilight state, they never actually lapsed into a coma. It held a lower mortality risk than the treatment that was frequently given to schizophrenic patients, and it therefore required less specialty nursing and meant that more patients could be treated simultaneously, and that was very important in wartime. Inducing altered mental states via chemical means was also at the heart of so-called narcotherapy, or narcoanalysis as it's sometimes known, a dramatic and drug-abetted form of psychotherapy that aimed at abreaction or catharsis by restoring the repressed traumatic memories of service patients to consciousness and thereby relieving the patient's neurotic symptoms. In narcotherapy, drugs took the place of hypnosis, which was difficult to achieve in some patients, in freeing up the tongues of these patients to talk about their experiences. William Sargant had much success with injections of sodium amytal, which he found not only relieved muscle tensions in psychiatric casualties, which was a problem for a lot of these men, particularly after Dunkirk. They came in with various, spasms of muscles. They began injecting them with sodium amytal to help them overcome that. But he also found, apart from relaxing muscles, it also made patients talkative. It gave them access to painful memories that their minds had buried. So he considered this drug the quickest and most convenient method for eliciting these memories, far preferable, again, to taking the man over and over the same ground in this endless talking therapy that he really didn't like, which he thought would cause the man additional emotional pain. Now, a famous example of successful narcotherapy conducted by Sargant, reported in the medical press, was the case of a soldier, a survivor of Dunkirk, who arrived at the Belmont Hospital with a paralysed right hand. Now, there was no apparent organic basis for this paralysis. And the soldier, though, could give no account of why his right hand wouldn't work. When he was injected with sodium amytal, however, he relayed a horrific story. On the march to the French coast, the soldier had found his brother lying by the side of the road with a terrible abdominal wound. His brother had begged him to put him out of his misery, so this soldier with a paralysed hand had dragged his brother into an adjacent field and shot him. Having recounted this story to Sargant, under sodium amytal, the soldier's paralysis lifted. Sargant was left to surmise that the soldier's paralysis in his right hand was not only a classic conversion symptom, but also a symbolic representation of the guilt and horror of having to shoot one's brother under those circumstances. Now, this story has a parable-like quality. There's a neatness to this kind of treatment that made it amenable to easy narration, and to an assumption that a soldier's neurosis could be magically cured with these injections. And I think this means that there's more to say. We can say a bit more about the performative aspects of this kind of treatment and the truth status of these experiences retrieved during narcoanalysis. Don't really have time to go into that here, but there's some interesting debates in the medical literature. Even though this story about the man shooting his brother is true, other men recounted under sodium amytal more dreamlike and fanciful experiences, and there's some interesting debates about whether memories had to be literally true in order to bring about this emotional catharsis that would clear up neurotic symptoms. What I did want to do, but what you can certainly do now thanks to the magic of the internet, also to the National Film Preservation Society in America, where narcotherapy was a technique widely used in the American Armed Forces. Last week, the National Film Preservation Foundation put up on its website a famous documentary film that has been very, very difficult to access until recently. It's called Let There Be Light, and it was a documentary that was put together by John Hudson, who directed The Maltese Falcon. But he shot a lot of footage towards the end of the war to put together a documentary on treatment regimes for American soldiers, and it features narcoanalysis quite a lot. And there was one scene I was going to show you with a soldier that comes in with a stutter. He wasn't a stutterer before the war, he developed it during the war. They inject him with sodium amytal, and he recounts the reason why he begins to stutter, and then when he's brought out of under the influence of the drug, he can speak normally. So there's a real, I guess, a kind of a neatness to this treatment that looks very good on film, and it's certainly something the Americans in particular wanted to emphasise. So although I can't show you the actual footage, you can definitely look it up on the internet, and the whole film's there, and it's available to download as of last week. So you can see that's a scene from, this is the stuttering man, and he's ecstatic now that he's saying, I can talk. Under sodium amytal. There's some stills from the film. They also use hypnosis as well, but not everyone, not all doctors can hypnotise people, and not all patients are amenable to being hypnotised, so they find sodium amytal is a much better method. I'll just leave it there. Alright, I should say in discussing narcotherapy that although it's the best known modification of traditional psychotherapy that's practiced during World War II, mixing psychodynamic techniques and other reconditioning measures was not unusual in wartime. For example, in the British context, in seeking to cure men who had broken down under unaccustomed stresses of noise, such as gunfire and aerial bombardment, who remained sensitive to these noises after battle, two psychiatrists repeatedly exposed their patients to BBC recordings of actual warfare to try and recondition them into not finding these noises so horrifying. Other practitioners would force their patients above ground during air raids to try and get them accustomed to these terrifying experiences. So it was aimed at reconditioning and increasing tolerance to unpleasant noises, but it was not thought to work on the unconscious in the same way that the narcotherapy was thought to operate here. It's also important to note that psychiatric opinion was divided on the utility of this technique. Psychiatrist J.A. Hadfeld who worked in a neuropathic military hospital where the treatment, as he described it, was mainly analytic in the broad sense and essentially aimed at achieving catharsis. He also used drugs as a means of abreaction, but he regarded its status as merely complementary and requiring additional work with free association to consolidate any recovered memories. So in other words, narcotherapy might relieve symptoms, but it did not necessarily address the fundamental conflicts that were driving patients' neuroses. To this objection, though, Sargant and other proponents had a simple answer, that psychotherapy alone could never reconstitute the makeup of the personality because, as he said, the neurotic cannot be freed of his neurotic tendencies. So there was a therapeutic nihilism at work that was rife in many ways in wartime. Pragmatic wartime psychiatry, according to Sargant, should aim to treat symptoms alone. Drug-assisted abreaction appeared to be quick and effective and was able to be used by practitioners unversed in hypnotic and analytic techniques. Alright, alongside these drug-assisted therapies, service personnel with persistent symptoms of war neurosis might also be subject to so-called convulsion therapies. And I've got a few slides to show you here. Convulsion therapies worked on the assumption that, much like insulin comas, disrupting chronically disordered brain function by extraneous means might restore a measure of tranquility to patients. Convulsion therapies were first introduced to British psychiatry in the early 1930s and ostensibly for the treatment, at least initially, of schizophrenia. But during the war, they become used on patients with what are described as neuroses. Convulsion therapy was quicker and therefore cheaper to administer than insulin comas, which required, as I said, people could be under or sleeping for a long time, and that required a lot of nursing and a lot of resources. These convulsion therapies were much quicker and in some cases could be done as outpatient procedures. Now, convulsions might be induced by cardiosol, a cardiac stimulant, soluble in water and therefore easily injectable, and that induced dramatic seizures in its recipients. Patients needed to be manually restrained by nursing staff to avoid injury, and the seconds before the convulsions began were also apparently terrifying for patients. The imminent seizure would manifest as a kind of acute but apparently sort of floating dread. And as such, cortisol conventions could have a punitive effect. The psychiatrist John D. Sutherland reported using 1 or 2 cortisol convulsions on a few what he described as uncooperative or unresponsive men who had developed conversion hysteria after combat. Since he concluded that the great majority of men who broke down in combat, and the group of men he was treating did include those who had survived ships being bombed and sunk, who had seen friends die beside them, who had witnessed women and children being machine gunned, he nevertheless regarded these men as compromised personalities prior to breakdown, and he theorised that any treatments could only affect superficial or temporal changes. Now, convulsions might also be induced by electricity, which during World War II was an even newer method than the cardiosol convulsions, and you can see that depicted on the slide. This new technology had the benefit of rendering the patient immediately unconscious, so there was none of the characteristic terror of the cardiosol convulsion. There was also apparently less risk of spinal fractures from violent fitting, which was a problem with the chemical convulsions, and in some instances ECT could be given as an outpatient procedure. Now, for Sargant, electroshock therapy was infinitely preferable to cardiosol, and he went to some lengths to procure a so-called shock box against the objections of the London County Council's medical advisors. And you can see here, Australians were using ECT as well, and this is one of those shock boxes, that the Army was using in Sydney towards the end of the war on neurotic Australian patients. So Sargant liked electroshock therapy. Again, it satisfied his need for efficient treatment, and he went to some lengths to get hold of one of these machines in wartime London, against the objections of the London County Council's medical advisors. And in his autobiography, he really sees the London County Council, which oversees the operation of these psychiatric hospitals, as very much misguided bureaucrats, and compares them to the caution they have around ECT to the initial rejection of Lister's antiseptic measures in surgery. He was similarly scathing of the Council's apprehension of another technique right at the margins of psychiatric practice, which was prefrontal leucotomy or lobotomy. This radical psychosurgical technique was developed in Lisbon by the neurologist Egas Moniz and the neurosurgeon Almeida Lima, and popularised in America just before the war by the neurologist Walter Freeman and the neurosurgeon James Watts. And lobotomy did require these teams, so you need a psychiatrist that would recommend lobotomy, and then you needed a neurosurgeon who would actually perform the operation. The procedure cut the white matter between the brain's two frontal lobes, destroying the connective nerve fibres. And the thinking around this, although there was not a terrible lot of really scientific thinking behind lobotomy, was that, again, similarly with insulin comas, with convulsions, it did something. It disrupted the brain's disordered functioning, which would give the patients a measure of relief. Some patients, it seemed, became less agitated after this procedure, but only some of them, though they also tended to become disinhibited and socially inappropriate. Nevertheless, Sargant adopted the procedure enthusiastically and unapologetically. Indeed, evidence from Sargant's published writings, his papers at the Wellcome Trust, and the paybooks and annual reports of the Belmont Hospital and the London Metropolitan Archives suggest that leucotomies were being conducted on service patients on a semi-regular basis, despite the misgivings of the hospital's superintendent, Louis Miskey, who was concerned about the irreparable personality changes wrought by such a procedure, and the apprehension of the London County Council. But we can see from the paybooks that Sargant, with a measure of subterfuge, had basically a neurosurgeon that was coming out to Belmont. If he thought people at Belmont wouldn't like that, he would transfer patients elsewhere, and this neurosurgeon was performing these lobotomies on service patients with intractable neurotic symptoms. And Sargant, I guess, displays, like he does with all the physical therapies, an unwavering belief in this extreme physical measure of treatments. His view, I think, is if a patient's symptoms lifted, that was a therapeutic outcome. That was the only therapeutic outcome. The changes to personality and particularly social disinhibition was not a problem for him. Up to the 1960s, he claimed that barring such accidents as a hemorrhage of the brain or a misplaced cut, I love how he sort of throws that out, barring such accidents, a hemorrhage of the brain or a misplaced cut, the beneficial effects of leucotomy can be obtained in all suitable patients without any of its previously distressing side effects. Now that's manifestly ridiculous, but he ends up with, at the end of the war, this evangelising belief in these kind of physical treatments as a way to alleviate psychiatric distress. All right, to conclude, what is the significance, or what can we say is the significance of these physical treatments for our understanding of psychiatry during World War II and the history of psychiatry more broadly? First, I think the relative neglect of these treatments in the scholarly literature demonstrates the wider fact that historians have tended to privilege theory over practice in writing the history of psychiatry. That's certainly true, I think, for military psychiatry. Focus very much on the theories of mind, explanations for disease, etiology, even diagnosis up to a point. There's not so much written about the actual practice of psychiatry. And I think these physical treatments show that it's problematic to assume that psychiatric practice always accords with psychiatric theory. Here, in the case of physical treatments for war neurosis during the Second World War, we miss a lot if we decide that because psychiatrists adhere to certain theoretic paradigms, and certainly the medical literature, these psychiatrists are speaking the language of Freud, they're giving out sort of psychodynamic, psychoanalytic explanations in this case. We're wrong, though, if they think they necessarily enacted the stipulated therapies for these kind of conditions. The stipulated therapies are talking therapies, but these are not the kind of treatments or the practices of psychiatry during the Second World War, not in all cases. I also think that neglecting psychiatric practice also means that we overlook key aspects of the patient's experience of psychiatry, and this has implications for the coherence and rigour of the social history of psychiatry. We need to understand not only how the psychiatric patient was constructed by psychiatric discourses, and there's a lot of work on that, and it's important. I think there's a lot to say about the way medical literature in particular sort of construct a kind of personality for the neurotic serviceman in the Lancet, in the British Medical Journal, and it's a pejorative kind of construction. That's all very important, but I think we also need to turn our minds to how the patient might have experienced treatment, things like the drama of narcoanalysis, the terrors of cardiazol, and that all very much goes to the wartime experience of many, many soldiers in Britain, in America, and in Australia as well. Finally, as I indicated at the beginning of this paper, I think there's something to say about the prevalence of physical treatments for war neurosis, about the implications it might have for the way we think about the way we divide up, the periods, the way we periodise the history of psychiatry, and in particular the way that we understand the biological turn and the rise of psychopharmacology in the later decades of the 20th century. Conventional wisdom holds that it was the development in the 1950s of leucotomies and other psychotropic drugs for the treatment of psychosis that brought what Edward Shorter, historian of psychiatry, has described as the psychoanalytic hiatus to an end, emptied the back wards of mental hospitals of their most intractable, chronic and florid patients, and returned psychiatry to the study of the brain. It has its apotheosis in neuroscience today, brain imaging, and explanations of mental disorder as having a very strong biological substrate. What I think what I'm trying to show in this paper, and what I think with a little more research I can show more convincingly, is that it's clear that during the Second World War, the reliance on so-called physical interventions for the treatment of neurotic service patients, not psychotic but neurotic service patients, suggests a different kind of chronology, and edging towards a biological or somatic treatment of neurotic patients at least a decade earlier than the accepted beginnings of the biological turn. In this sense, I think we can understand wartime psychiatry as prefiguring a marked change in psychiatric practice that has repercussions to the present day. And I think I'll leave it there. I ran a little bit short, but yeah, thank you very much. Publishes early and he publishes often, which is interesting. So we'll get a cohort of patients that comes into his hospital. 2 weeks later, there'll be something in the Lancet about what he's done, the conclusions that he draws. So he writes a lot. He writes, as I said, a textbook at the end of the war. He also goes on to an element of notoriety. I think he's on the defence team in the Paddy Hearst trial because he writes popular books on brainwashing and these kind of things. He comes out in the post-war into the 50s and 60s and 70s as a real anti-Freudian, physical methods of treatment, quite cavalier in the way that he treats patients, doubling doses of things, giving people double the amounts of convulsions if he thinks it will make them better. So a very strong presence in medical literature, also popular literature. But I think you're right, and the history of psychiatry is like you get these personalities that they end up at a certain hospital treating a certain cohort of men, and if they're self-publicisers, they can really shift the discussion. He's an interesting man. He writes an autobiography, which is very interested, and he's very sort of self-assured right from the beginning. There is a suggestion though, and this would be difficult to write, but his papers are in the Wellcome Archive, and you can see a lot of his drafts. And you can see the way that he cuts out hedging phrases. So he'll say something like lobotomy or leucotomy may assist in the treatment of war neurosis. And he'll cut out may. And he sort of revises his drafts and the data that he collects in this very sort of positive way. The other thing to say is that there is a suggestion that when he was a young man, he may have had an episode of depression. Not unusual for psychiatrists, actually, when you think about it. But it may be something of that there's just occasional phrases in his writing when he talks about the pity of someone in that condition and how dreadful the experience of depression is. And it's easy, a lot of people characterised him as kind of monstrous, that kind of stock figure in the movies of the mad scientist. There's certainly things to be said about these going around lobotomising people and all these kind of things. But at the same time, there is a sort of there's a sympathy in him as well. I mean, I think he thinks he's doing good work. He's ridding people of these intractable symptoms. He's bringing them out, patients that might have been in hospital for 2 or 3 years. He sees his role as bringing them back into community. If they're impaired in other ways, if they become socially disinhibited, it's still a therapeutic effect. He's not worried about their souls and their intelligence, but he's worried about their social functioning. But I think you're right. History of psychiatry is tied up with these individuals, particularly before I'll stop in a minute. He hated the advent. I was going to say he hated the advent of the double-blind clinical trial.
Really,
he absolutely hated that. Yeah. And he said for various reasons, it's wrong to give people placebos because you're prolonging their suffering. But I think it was actually because he enjoyed, or his mode of operation had been small groups of patients, see what happens. Test things on them, see what happens, and go on from there. I mean, recovered for Sargant, and recovered, say, in the British, in the medical psychiatric literature, is out of hospital.
I see.
And
Okay.
that's where it becomes difficult, because particularly these men, there's some suggestion, and people are saying this in the journals as well, that this man that stutters, he has this amazing recovery that's captured on
I
film.
see.
But then what happens in 2 months' time, in 3 months' time?
Of course.
And there's a suggestion that unless you're tracking these patients, which, because it's not Scandinavia, they're not doing with as much efficiency, we don't know how many people ended up back in hospital or ended up living lives that we would now say are dysfunctional. Some men that ended up drinking, dying young, suiciding. I mean that we do need to know that, but the cured is out of hospital in the literature, between a 20% success rate and a 70% success rate, depending on how they count, how they define things. Actually, during World War II, I mean, the main thing they're interested in getting people out of hospital.
Right.
If they're in forward combat units, it's getting them back into battle, into action. And there's lots of disputes about how you actually count that. Is it a success if you can return a frontline soldier with a gun in his hand back into combat, or is it enough if he digs trenches or digs latrines for the rest of the war? I suspect that the cases that don't get out of hospital are reclassified as psychotic or psychopathic personalities, which infers a much, a chronic and condition you can't really alleviate. I want to say yes, because I think there was a stigma, but not to the same extent that there might have been in the Soviet Union, in Japan, and in other countries. People certainly recognise they call nerves, bad nerves, as a consequence of war. It's not as much as World War I. I think it's a recognised condition, but I still think there is you can pull out a kind of pejorative flavour, even for the psychiatrists. I mean, psychiatrists will even say, and this I found this hard to fathom. A man that goes through a dreadful experience after Dunkirk, something absolutely horrible, sees his friends killed or outside, there is still a sense that if you break down in those circumstances, you were compromised from the beginning. You're not a fully integrated. The fully integrated personality recovers from trauma and goes on.
So the construction of masculinity, isn't it? That
it is.
Wartime.
It's not as overt. It's not as overt as in the First World War. There's not the overt classing either. I mean, there was thought that it was the lower classes that broke down in World War One. Psychodynamic theory sort of says, look, it's the unconscious, and that sort of applies to people equally. But I think you're right, and there's a lot of there's a lot of underreporting as well. And probably at the time, men who didn't end up in hospital, but who went home and drank themselves to sleep every night. I mean, now we would say, psychiatrists say, well, it's post-traumatic stress disorder. But it's it doesn't necessarily, they don't necessarily find themselves in formal diagnostic. But that sounds absolutely fascinating stuff in the Soviet Union. Yes. I mean, that would be just so inimical to that put those political institutions there. Wonderful. It's a really interesting question. I can say in the British case that those pre-selection regimes that the Americans would do, often been administered by psychologists rather than psychiatrists, that give people personality tests. Do you like girls? These kind of things. And if you didn't get enough answers right, you're out the door with, I think it was a 4F they put on your form, and everyone back in your hometown thought that you were crazy. And this was happening at amazing rates until they had to sort of lower the bar because they weren't getting enough men in. The British try and do that after a few years, try and weed out the neurotics, the congenital neurotics. The Americans are certainly influenced by the British in terms of the narco-analysis and the drug therapy. I'm not so sure about the Australian case, and I don't know if you know Yorick.
Yeah, I think there's a paper coming out on this exact question. I was like, I can't quite remember where it might even be the Institute of General Sexuality.
Yeah.
Anyway, I can get back to you with that.
But
it's coming out shortly.
It would be fascinating because the forces operate their own psychiatric units in other countries, and it would be fascinating to know. I know that Sargant has contact with American psychiatrists, but it'd be fascinating to know how much they are actually influencing each other's practices. I suspect quite a lot. But I think the post-war story in the countries is different. I mean, there really is a rise of psychoanalysis as a middle-class therapy, particularly in America. I think is different. It's a different story in Britain, where you've also got the NHS, which I think influences the way that psychiatry is practiced and makes this kind of efficient physical treatment more attractive. But again, it all goes to what are psychiatrists actually doing to their patients? If we can find that out, that's great. It did certainly take over established hospitals, very clear about sequestering wards for military patients and separating them out from the civilian mental patients. I don't think it was a designated psych hospital, but it may have been after the war. It may be that veterans did go there. I think the major ones here, I'm having a complete blank down. There was one near Goulburn, and one, the Roselle. They had people at Roselle as well, the old Roselle Hospital. I don't know so much, the private institutions after World War I, definitely. Marina Larson has some really interesting work on the family, but also the private sector in looking after shell-shocked veterans. World War II, I'm not so sure. I suspect maybe less because the structures were already in place in terms of the government taking care of these people. But again, the history of actual institutions is fascinating. Yeah. I think in the wartime context, it really just comes down to efficiency. In the way that the Americans take a preemptive approach and try and weed out people that will later end up in hospitals and need pensions. The Brits are trying to do the same thing, but in a more ad hoc fashion. So they're scrambling at the start of the war. By the middle of the war, they're putting in these tests that really, I mean, it's absolutely, these are guys that sort of, adhere notionally to a kind of Freudian concepts of talking cues and therapeutics, and they're making up these metrics and these tests and sort of saying, oh, well, you're this type of personality, hopeless, off you go. So I think it's efficiency. It's about forestalling people becoming chronic patients and being a drain on the pension system. There are concerns, I guess, at the beginning of the war about air warfare, as sending the civilian population mad, but also having a toll on combatants as well. Death coming from the air. Is that the kind of thing that you're asking, Wayne? Like almost sort of a structural explanation for why
it is.
psychiatry gets pushed in there?
There's also a personal side of this. I've got 3 children. One of whom works at Concord. She's a physiotherapist.
Yeah.
Another one, social worker, drug and alcohol counsellor. And Emma's got a medical background, and they're forever fighting about, according to, is it drugs, is it behaviour, is it context. So they work in teams. You have a number of drivers based on people's own experience and training. And I get the sense here that the motive, the background, the context, all of these things come into play. So that it's not just a question of what type of driver, what type of personality, what type of context. It's really the ultimate transdisciplinary study, isn't it?
Yeah, it is. But having said that, I mean, I think what you were saying about your kids has made me think of this. I think there's a medicalising impulse. And if you think about the history of medicine around the time, blood tests are allowing people to diagnose particular conditions before the patient would come in. The doctor would look at you and try and diagnose you from clinical signs. Now you can do blood tests, there are x-rays, and there's probably a similar impulse in some ways. If we can medicalise, if we can have certain categories of personalities, certain categories of diagnosis, then it just makes things much more efficient. I mean, I suppose that doesn't really, you see it with the Americans with the DSM, it really comes to fruition there, a kind of medicalising diagnostic practice. One great phrase in a Lancet article it calls neurotic casualties grit in the machinery. And I think that is a fantastic phrase. They refer to men as material.
Yeah.
And it is this idea that the nation at war is a machine that is made to run. These neurotic casualties are grit in the machinery that we need to get out. But we also need to rehabilitate them sufficiently that they can function in the post-war world, in industry. There's a lot of talk about we need to make sure that they can work in factories and they don't get the kind of industrial neurosis that people are talking about as well. And in this post-war world, they need to be functioning and employable citizens.
Maybe we should continue this exciting conversation over coffee. So can we thank Elizabeth for a fantastic paper? What a great way to finish the seminar during this semester. It was lovely.
Yeah, thanks very much for inviting me.
Yeah, no,
great to be here.